That was terrific. Not only did they, share with us their experience, and we've heard in the audience of others who have a similar experience, they actually set up our next panel perfectly because we actually talked about what the patient population, segmenting the patient population, and then how do you actually match the care elements or the care design with that segmentation. So I'd like to welcome Melinda Abrams, who's the Vice President of Delivery System Reform at the Commonwealth Fund and a member of our Planning Committee, and Arnie Milstein, the Director of the Clinical Excellence Research Center and a Professor of Medicine at Stanford University, who are going to talk about patient taxonomy and promising care models. So taking the example we just heard about and extrapolating that to how does it look across other programs and other opportunities. So you can, and you can speak from the podium, or you can, if you'd like, either.
Okay, this way I can move. And I'm short, so this way you can see me. All right. First, I really want to thank the Peterson Center on Healthcare, as well as the National Academy of Medicine and Peter Long for inviting me to lead this subcommittee, this subgroup, to wrestle further with this notion of a patient taxonomy. So I'm really here to report out what it is we discussed and some of where we landed. So, but this is a part of a two-part presentation. I'm Act 1, Arnie is Act 2, and we'll really talk about where we are on this taxonomy and what this means and where we landed, and then Arnie has the unenviable task of trying to see whether or not it actually matches with programs and the potential utility of it. So this says patient taxonomy 2.0. That's probably a little ambitious. It's probably 1.1, but nonetheless, we'll proceed. These are the members of this subcommittee, and what is, I'm really grateful for all of them. A number of them are on the planning committee, but a number of people actually agreed to participate, and it was a really good mix of people running programs or systems, and then researchers trying to think about how do we identify these high-need patients based on their medical needs, their social service needs, and also on their behavioral health needs. So thanks to this committee. So I think you've heard it really loud and clear, but again, to review, what is it we're trying to accomplish? Why are we doing this? So it's, again, the high-need, high-cost patient population, the patients with medically and socially complex needs are very heterogeneous. And there's not one intervention that is going to meet all of their needs. So we need to identify kind of the subgroups of patients with common characteristics, common needs, so that we can effectively match the intervention, the model, the program, to those subgroups of patients. It's very straightforward. That is what this is about. And then one of the things that you've heard a lot, both from the previous panel, is how much, there's not just medical needs when you start talking about this population, but a lot of behavioral health and social service needs. This will come up. So what did we do? This is, I would hardly call this a method slide, but this is some of what we reviewed really, in my opinion, important and exciting work led by Dr. Ashish Jha and Jose Figueroa, who are here, as well as some additional work done by a team at the Commonwealth Fund, really under the guidance of our external advisory committee. We really debated a lot about kind of who is it we're trying to reach with this, what are we trying to develop, what is the purpose, and where is all this going to end up. So the points that I really want to stress are, when this committee started talking about a patient taxonomy or segmentation of these high-need patients, we were really thinking about leadership and management of large health systems or of health systems and for payers. We weren't necessarily thinking, it's not that they don't need to do it also at the front line, but what we were really thinking is that in terms of planning. So if you're a chief medical officer at a Medicare or a Medicaid ACO, and you have to understand your patient population, you want to understand the segments so that you can plan, like what workforce do I need to bring in? Which interventions am I going to bring in? Someone asked the question earlier, what are the infrastructure that I need to build? that was kind of that's the perspective, the lens through which we were trying to do this. I think that a whole other team could do this, thinking about, and actually Dr. David Dorr, who was on our committee and has a project from with the Commonwealth Fund, how do I do this for my 2,000 primary or 3,500 primary care patients? So that's the target audience and the purpose. Really wanted to build on the work that had been done so far, recognizing there were some limitations with it, because really wanted to embed the behavioral health component and the social service need component. And I think you're going to hear this a lot in the next 5 minutes. It's a starter approach. It's illustrative. It's a set of principles. This is not what we are not going to, what will be in the chapter is not something with a lot of numerators and denominators that are, super defined, that you could just hand over to someone to kind of plug and play into their large data set. We think that it is informative. We think it is one approach. There are more than one approach. I have a lot of caveats around that. Okay. So some of the themes, it must extend beyond clinical care. We don't really need to get into why. We've just heard really well from Ms. Butler and also from the MedStar team that the idea also is that taxonomy must be actionable to inform the care. This whole thing around analytic versus operational. So we looked at the data. We looked at the literature, and then we had to reconcile it with all the health system leaders who were part of this committee and be like, okay, that sounds great where the evidence is taking us, but that's not actually the reality in which I live. I have a very hard time getting real-time data. I have to figure out who to train. I have to kind of change the workflows. This is not all that easy to do. So it was very much where we also, again, where we ended up was trying to marry and reach some consensus based on experience, expert, literature, data. So those are the themes. One of the things so we talk about this, we use a lot of words, and we really need to make sure that we kind of I just need to do some level setting on the terminology and what do all these words mean. And I also should say, it's not that these terms are widely accepted throughout the field. This is what our committee, these are the terms that we rested, that we came up with. So there is a difference between whole population risk stratification. 20,000 patients in my Medicare ACO. There's a difference between low risk, rising risk, high risk, super high risk. That is risk stratification. Where the taxonomy comes in is among those that are highest risk, right? What Dr. DeYoung was saying, that 5%, that 3%. For that at the top of the pyramid, they're a really diverse population, all right? And so that's the population we need to segment to effectively match them to the programs. And so that's where this taxonomy is. It's at that top, recognizing that they're not all one kind of patient. You have your frail elderly, you can have your homeless diabetic with schizophrenia, right? They're all high need, high cost. So that's the segmentation part. Targeting is really not what we're going to talk about today, but targeting is even within that segment, not all of them need the same level of intensity of complex care management. And what we found in experience talking to providers and also from the literature and the evaluations is that the most successful programs do that next level of screening again, and they identify those that really need the complex care management, even though everybody's on the radar, maybe everybody's on the panel, but they're not necessarily getting the same level of intervention. Okay. This really depicts what we've already talked about all morning. You modify the way you structure your intervention based on the needs that may not only be medical, but also what you would do for someone if they have bipolar disorder or if they're homeless versus if, major complex, it varies. And thank you, David Labby, who is in the audience, for kind of reminding us over again that how important it is to have this biopsychosocial framework. And this is yet another depiction of really the same idea, again, to show the ways to get to better health for this population with complex needs. It has to be comprehensive. Okay, so where we landed. So I've done all this. We recognize the importance of the social determinants, and yet the medical grouping of patients, while it has its limitations, it's a feasible starting point because it's actually most of the data that people have. So if you look at your claims data, so again, we were trying very hard to come up with something that is illustrative but potentially actionable, right? So it's a feasible starting point. But of course, the gold standard, the bullseye, would be incorporate the behavioral and social factors into the taxonomy. Some of the times it's in claims, sometimes it's not, sometimes it's in EHR. It really will depend on your system and what kind of data you have. So after a review of everything that Ashish and Jose have done and the Commonwealth Fund team had done, the group decided actually that we didn't really need to do more work on the medical-oriented segments, but we really needed to do two things. One, we really would like the National Academy of Medicine to make a statement in this report about the need and the value of segmentation, of having a patient taxonomy among those with high needs. So that's, one. And two was to present a conceptual model that offers guidance on how to embed. So kind of begin to take us that one step further. Like, how would you embed some of these social risk factors and behavioral health factors into the taxonomy of high need patients? Okay. So this is our conceptual model, and here's how I'm going to try to walk you through it. So step one is, as I just said, you're going to start with the medical groups. This really largely builds on the work from Harvard School of Public Health, Ashish and Jose. A couple of things about this. So I'm going to start, first is that the functional limitations, which are critical, we've already heard that, critical to meeting the needs of this population, they're baked into these medical groups, right? So that if you had two or more functional limitations and you were over 65, you're immediately in the frail elderly group. You could also have major complex chronic, but you're going to be in that frail elderly group. And if you were under 65 and ESRD and qualifying for SSI, you're in the non-elderly disabled. You also may have major complex chronic, but your functional limitations actually drove which group you were in initially. And then the other ones, and people in the audience, we can give you the definitions, but it's just somewhat more conceptual. I just wanted to know that the functional limitations are baked in. Next, I want to draw your attention to the bands across the bottom. So the idea here is that behavioral health issues and social service needs cut across every group, right? It's not a separate segment. It cuts across all the segments. So that's really important. And how this works, potentially, is that let's just say you are someone who's got major complex chronic conditions. So you have diabetes and heart disease and kidney disease, and you have ample social support, and you have no behavioral health conditions, right? So you might have a certain kind of team, a complex care manager. But let's say you're also severely depressed. Well, then maybe your team actually adds someone who has a background in psychology or social work, manage that. Or let's just say, not only do you have those major complex chronic conditions, you're severely depressed, or you're bipolar or something, and let's say actually you have unstable housing, you have an unstable food source. Then the team, again, changes and adds more people and does different things. So, and I think the MedStar is a perfect example of this. But the idea is that the behavioral health and the social service needs cuts across all the bands, but once you're kind of, it's not that you can't move in between the segments, but the notion is that how you would build your team or think about the infrastructure you have to build actually goes within up and down vertically. And again, of course, people move. So frail elderly can then move to advancing illness and so on and so forth. Okay, so that was piece one. The next component is on the behavioral health and the social service needs. So we had a whole process here, and this is really the, in many ways, kind of the very new and unique contribution of this group. We gathered feedback from various work group members. We looked at the literature. We looked at various IOM reports in particular. We collected screening tools that are out in the field that people are using to assess and screen for social service needs. And then we voted and we pared it down. Okay, and so here's where we landed. So we really wanted to come up with a small number. Here's where I'm just going to once again remind you of our goal, right? This is not meant for an individual care manager to figure out the exact services of an individual patient. I would collect a lot more information, right? This is more about how does someone move from group to group? So let's just use an example, food insecurity, right? Would knowing that really move someone into a different segment somehow? It would affect how I deliver services, but from a planning perspective, the committee felt that the housing was probably covered some of the food insecurity. There was some overlap there. Now, this is, again, just like the larger kind of segmentation approach. It's not that these are the right ones or the best ones. This is a starter set. This is just where we, that really just wanted to emphasize that that these are strong examples, and some of them have more evidence than others, to be perfectly honest. So that's where we landed, and I think that's it for my presentation. So thanks very much.